Welcome back to part 2 of our CDA OASIS case conference. Thank you to those of you who submitted your responses and showed me how you would manage this case. And just as a reminder, this is the case that we presented in part 1. As you can see from the photograph, it's a patient that presents with a fistula just buckled to an implant-supported crown that was cemented on a custom abutment. So this is how the patient presented. And what I'd like to do over the next few minutes is to discuss how we address this situation and what you can do to avoid this sort of situation from arising. So how we manage this case. First off, the diagnosis is basically it's a fistula that was presented as a result of residual cement that was caught subgingivally under the restoration. So the etiological factor has to be removed. We have to remove the cement in order to address the problem. And so this is how we addressed it. As I said, you've got to remove the crown, and that was the first step in this process, removal of the implant crown. Now, unfortunately, the crown was bonded onto the abutment, so we had to cut the crown off, but we were able to preserve the abutment and reuse it. So that was the first step, and you can see from the photograph where you assess the soft tissue, you can see just on the lingual of the implant, the residual cement. So the next step was to remove the residual cement, and this is what it looked like. So it's quite a large piece of cement that was left subgingivally, which resulted in the fistula developing. And again, this was asymptomatic. Patient didn't feel anything, but just noted the bump. And ultimately, the patient was referred, we provided her with provisional crown, and she was referred back to her general dentist, who made the definitive crown. And once the definitive crown was inserted, after a few weeks, there was complete soft tissue healing and no further issues. So that's the presentation following our management. So now the question you have to ask yourself is, how can you avoid this sort of situation from arising in future? Anytime you cement a crown on an abutment, an implant crown, there's always a chance of residual cement being caught subgingivally and resulting in this sort of situation. So I want to share with you a few tips on how to avoid this. So the first tip, it's a bit tongue-in-cheek, but basically avoid cementation if at all possible. So traditionally, when I started out with restoring implant crowns, my preferred method of restoration, which was the same way it was back then and it still holds today, is that whenever possible, I like to have screw-retained restorations. So if at all possible, I avoid cementation. Now, in certain situations, we know that we can't always have a retrievable screw-retained restoration. So in situations like that, you are forced to have custom abutments and cemented crowns on top of it. So if you cannot avoid cementation and you have to cement, what you should do, what your lab should do, is to design the crown and the abutment in a manner that's conducive to cementation. So what do I mean by that? Basically, your abutment margins should be no more than 1 millimeter subgingival, so you have access to cleansing the excess cement. So that's something that's very easy to do with custom abutments that we make today, and we can design them to fit within the confines of the soft tissue and create your margins so that they're not deep and subgingival, where you can get higher incidence of cement entrapment. The second thing that you can do in keeping in line with this recommendation is you can come up with some interesting abutment design considerations where it's easier to remove excess cement. So I'll just show an example of this. What you're looking at in this screen over here is a custom abutment that is screwed onto the implant, but you can see there's a chevron on the lingual, the palatal aspect of the crown, that when it's fully seated, you can appreciate the crown margins are super gingival, and it's very easy to clean off any excess cement. So there's really minimal risk of having cement entrapment underneath the soft tissues. So this crown cemented clinically, you can appreciate the excess cement extruding through the lingual and really a removal of the residual cement, so that we really minimize the possibility of cement getting entrapped underneath the soft tissue. The other thing that you can do is you can minimize the cement volume that you place by creating essentially a duplicate abutment. So I want to show you a very quick and easy way to do this, chairside. This is a chairside example. You can also have the lab fabricate a dummy abutment for you that you would use prior to delivering or cementing the crown. You can use a duplicate abutment. So let me show you what I mean by this. So here is a cast of a mandibular cast where we made a digital impression of 3 implants that you can see, one in the 3-5 site and 2 in the posterior right mandible. And what you're looking at here is a cast of the abutments, the custom abutments that were made, or a replica of the abutments, and here are the final crowns. So to show you the custom made abutments, you can see that they're titanium nitride abutments, and you can appreciate from these slides as well, the margins are customized based on the patient's soft tissue. And so here are the crowns seated on top of the abutments. And so the objective is that you want to create, or I created a dummy or a duplicate abutment, and it's a very simple chairside technique that you can use. So what you're looking at here is the crown with some Teflon tape just placed on the intaglio surface of the crown. And we simply inject a silicone, a PVS, a bite registration material into the crown itself. And then I attach a small, an end of a Q-tip or a micro brush, whatever you want to create this sort of holder for the dummy or the duplicate abutment. And here you can see essentially a replica of the abutment that was positioned, that was fabricated for this patient. So now what you can do is you can see how nicely the crown fits on top of that duplicate abutment. And at this point, what we've done is we've delivered the abutments intraorally. We've tried in the crowns, make sure that your contacts, occlusion, everything is ideal prior to cementation. The abutments are torqued into place, and now we utilize this duplicate abutment in this fashion. We place the cement inside the crown, and then we just seat the crown on this duplicate abutment, and you can see all the extrusion of the cement through the crown. And then what you do is you simply lift off the crown, and you can see that just the inside, a very nice, thin, even layer of cement is present in the intaglio surface of the crown. So now when you go to deliver this prosthesis, if you go ahead and cement it, which is what you're seeing over here, here are the custom abutments that were torqued into place to the manufacturer's specification. We seal them off with, in this case, Teflon tape and a sealant, Cavit at this point. And then we take that crown that's been placed on the duplicate abutment with the cement in it, with all the extruded excess cement removed from that, and we simply position it on the abutment like so. And by doing so, there really isn't a lot of volume of cement to be lodged subgingivally, so we really minimize the risk completely. So we've done 2 things over here. We've designed custom abutments with margins that are just 1 millimeter subgingival, and we've created this duplicate abutment that allows us to remove any excess cement prior to delivery of the crown. And by doing those 2 things, we really completely eliminate the risk of having cement caught subgingivally, which could result, as you can see, in a fistula developing. So with that, I thank you for your attention. I hope you enjoyed the presentation and that you took some practical tips out of it. By all means, I'm always welcoming any further discussion. If you have any questions, feel free to email me or contact us directly. And we look forward to helping you out in the future and to contribute to this discussion. Thank you.